Good afternoon. I'm Mark McClellan, and on behalf of the Duke Margolis Center for Health Policy and the Alexandria Summit, I'd like to welcome everyone today to our webinar on reopening in the COVID-19 era. This is our fourth webinar in a series in collaboration with Alexandria Summit, focusing on a range of key issues involving medical technology, innovation, and public policy in responding to the COVID-19 crisis. In previous events, we've focused on diagnostics, diagnostic testing, innovation in particular, and on COVID-19 therapeutics and on vaccines. So today we're going to focus on what employers, both public and private, are considering as we proceed with seeking to reopen the U.S. economy successfully. We'll hear both from employer perspectives and from public health and public policy considerations in this challenging time for the United States. We'll be discussing a range of perspectives in this work, and you'll get to hear from stakeholders from the payer community, the innovation community, the business community, and public policy experts. I'm going to start with a brief overview of the event today. It's going to include opening session with Andy Slavitt, who's the Director of the United States of Care, former acting administrator for the Center for Medicare and Medicaid Services, someone who I've been collaborating with closely on many aspects of this response. And we have several joint projects between the Duke Margolis Center for Health Policy and United States of Care. And then we're going to have two sessions. The first on back to work strategies for employers, both in higher risk and lower risk employer settings, with a focus on the private sector. We're going to talk about symptom tracking approaches, workplace modifications, testing capacity, and also tracing and containment approaches. And then for the second panel, we're going to talk about some of the public health considerations, particularly for vulnerable populations where government action is likely needed to augment the private sector efforts and where we've been seeing a disproportionate impact of the pandemic so far. So there's the agenda for today. We'll finish up by 2:30 and on to the next slide. The reopening in the U.S. has happened based on guidance from the White House that in turn reflected work by people like Caitlin Rivers and others who are participating in this event on criteria for safe reopening that included key considerations like case rates falling reliably for at least 2 weeks, testing capacity that was enough to reach most of the people who were experiencing symptoms and making it possible to contain outbreaks, although contact tracing was not explicitly included in the gating criteria. And then an important one, whether hospitals had the capacity to meet the potential surges in demand that would occur with reopening going forward. And I think what we've seen, if you go to the next slide, is that most states, almost all states, did not wait for those criteria to be in place before reopening. This comes from a website, covidexitstrategy.org, that has collaborated to produce a lot of data on the criteria that the White House and others have recommended for reopening. It's a project that both Duke Margolis and US of Care have contributed to. And I think the main thing to take away from this chart is there's a lot of red, especially when it comes to trends in cases, with many states reopening without having experienced a decline in case rates, and also limited access to testing over the last few months. And while that's been increasing, still short of capacity. And on to the next slide. As states were reopening in this context, Andy Slavitt led a collaborative effort, bipartisan, on how to adjust to these circumstances while still being able to reopen safely. For example, by placing an emphasis on steps that could be undertaken alongside reopening to contain possible outbreaks if caseloads were not falling when states were reopening. It's keeping in mind that many states were able to avoid a big surge in the spring because of the shelter-in-place orders. So we're starting from a very low level, which potentially permitted, even though cases were rising, the opportunity to contain the outbreaks further. And we've seen since then, in the past month, if we go to the next slide, several things that reflect goals for the reopening, but several areas where the results are falling short. Testing is substantially increasing at this point, well over 3 million tests per week, on track to perhaps being in the 6 million or more range, according to HHS projections by the fall, and some private projections, even higher level of testing availability with new technologies coming online. We'll talk about some of that today too. But despite a reduction in cases that had been going on through April and May, as the big outbreak peak areas in places like New York and New Jersey and some other areas, urban areas, came down, we've seen increasing cases from other parts of the country that started off at a low level and are continuing to rise. So it's a mixed picture across the country, but rising cases overall due to what we show on the next slide, a number of states having that previously were at low levels of cases overall, showing substantial, perhaps exponential growth this week. Places like Florida, Arizona, Texas, North and South Carolina, even as some of the states that were harder hit earlier are continuing to decline. And if you go to the next slide, with these trends, a couple of other points to note. We're not seeing hospitalizations overall increase as much as the increase in caseload. This is a reflection of the fact that more cases are occurring in younger individuals. So we've taken more steps among people who are older, in nursing homes and other high-risk facilities, to contain outbreaks in those settings, so that the hospitalization rate among the cases, who are now lower in average age, tends to be lower. And on top of that, even though hospitalizations are more level, increasing some in some states, decreasing in others, overall going up at a lower rate than the cases, death rates are still going down. Now, deaths are a very much lagging indicator. They reflect what happens weeks after cases occur. So this could still change, but it may also reflect some progress in medical management of patients, especially hospitalized patients, where we've seen new evidence in the recent weeks and recent days of techniques that work. Anti-immune treatment, immune reduction treatments like dexamethasone, treatments for clotting, where new studies are expected to come out soon suggesting some benefits, better ways to manage patients who are having severe breathing problems while avoiding complications on a ventilator. So the hospital care does seem to be getting better, with the death rates, the case fatality rates by age falling, especially in older age groups. So that's some good news amidst the rest of this picture. But I wanted to end my opening with some comments about what we've seen from the beginning, but we're seeing more data now, as you go to the last slide, of the stark disparities in case outcomes and occurrence of cases across demographic groups and other health risks. So this is one example of those studies that have been put out recently. This one from the Centers for Medicare and Medicaid Services on Medicare beneficiaries, where we see that Blacks have been hospitalized with COVID-19 at rates about 4 times higher than whites. And while Blacks have the highest rates of hospitalization, Hispanics have hospitalization rates about twice that of whites. Asian Americans also have higher hospitalization rates too. And beyond that, there are vulnerable populations from a health standpoint that have also been hard hit in the Medicare program, with the highest rates among patients who are dually eligible on Medicare and Medicaid, and for patients with end-stage renal disease. Both of these groups have significant health problems that require them often to be in so-called congregate settings, dialysis facilities, nursing homes, where the outbreaks have been particularly tough in the last few months, even though we're seeing some progress. So very important disparities underlying all of this. And so with that context, Andy, I'd like to turn to you. You've been working on this set of issues from a range of perspectives, particularly at US of Care. We've appreciated the collaboration, including on the open safely criteria. What's your perspective on how we're doing with respect to the goals set out and the specific recommendations set out in open safely and some of the similar kinds of efforts to help us reopen this country effectively?
Well, thanks, Mark, and thanks to Duke and Andrea. It's a really important conversation. And there's no perfect answer. I think we have to be a little bit at peace with the fact that we are all going to be watching governors and local elected officials do their very best, take their best effort. It feels like we're at the part of the pandemic when everybody needs a bad guy. I think that the movie plot of 2020 won't be complete unless people can get blame. And it's frustrating for people, I understand. But the truth is, it's not the fault of people having barbecues. It's not the fault of people going to protest. It's not the fault of the governors. It's not the fault of the president. The fact is, this is how the virus works. The virus is the ultimate bad guy here. And yes, we can be doing better in how we respond. But I think part of getting the response right is not beginning every conversation with looking at a state with case growth or even hospitalization growth and starting by assigning blame and responsibility. I don't believe there's anybody in the country that wants to see more hospitalizations and more deaths. So people are doing what they can. Now, I think the data you pointed out, Mark, would show that we're not responding as well and as uniformly as we could. And that's very costly because it's creating more community spread. And I worry that as people see things like death rates come down, as we get better therapies and so forth, they'll forget the fact that this isn't a question about whether or not us as individuals are necessarily at risk, but it's whether or not the most susceptible people that we're going to come in contact with, or that people we come in contact with are going to come in contact with, are susceptible and are going to pay a price. And as you said, the disparities here for people who have lower income, black or brown skin color, or they're older, they're sicker, they're lower income, they're going to pay the price, and many of them are out there and they can't socially isolate because they don't have the means to do it. So I think that's kind of where I would start the conversation.
Yeah, and just to pick up on this last point, so behavior does matter, behavior interacting with the virus. The virus is the bad guy in all of this, and you can completely understand the frustration, especially among younger people who've been locked up, having trouble with work, everything else, and don't face personally a very high risk from the virus and don't seem to be that concerned about getting it. But the point that you made of the spread going through them and community spread to older individuals at home, family members, other people in their neighborhood, especially if they're in kind of close living settings in their neighborhood or in transportation, is a big part of what seems to be going on with this new surge. Have you seen any kind of promising approaches out there for how to engage that part of our community more effectively in helping to slow the spread under these circumstances?
Well, it's become a kind of cultural matter, and I feel like the reports that you've given and the meetings you've held around the therapies and around vaccines, it's like we're succeeding in our graduate school education, but we may be failing in our kindergarten education because we have large parts of the country where the virus is spreading to now, namely the South and the West. 9 of the 10 largest cities where the virus is the highest growth today, which are in Florida, Texas, and Arizona, North Carolina, California. 9 of the 10 largest cities have reported very low mask use. So if not that there aren't places and states that aren't doing it well, but the places that are obviously doing it the best are places in Europe, in Asia, in Oceania, where yes, there's sacrifice. People are going without income for some period of time. People are socially isolating for some lengthy periods of time, but they're coming out of it and they're living with the virus, and their economy is probably going to bounce back stronger because people will be more comfortable doing the things that drive an economy, spending money, getting on airplanes, signing leases, and things like that. We have a desire to get the economy open, but when we do it this way, we only crack the door of the economy. So what are those places doing? They're wearing masks. They're being respectful of others. They're not congregating in super spreader locations like bars, unfortunately, churches, casinos, places where it's just very, very hard for there not to be community spread. And, I think if we carved out a set of activities, if we approached it from the other direction and didn't say, what are all things we can't do, but said we can do so many things that are turned out to be safer than we thought or are very low risk. But there are a handful of things that are going to cause this virus to continue to spread and people to continue to suffer. I think we'll be better off. So the states that are going cautiously and are stepwise, while I think they may be getting a lot of grief and people are impatient, are the ones that I think are going to end up doing the best.
And Andy, and a lot of the work that we've done and that others have done, much of the emphasis was at the state level, understandably, or that's where a lot of the authority is and a lot of the resources are being directed to contain the pandemic, to collaborate with employers and so forth. But it seems like many of these issues are arising kind of much more locally. And we've seen some of the states just this week that were early to reopen, start to take steps, maybe not at the governor level, but at the mayor level, at the county level, along the lines that you're describing, more requirements around masks, more steps. As you said, it's not necessarily a long list of activities, but it is a certain type of activity, namely the ones where a lot of people are close together for a significant period of time. They're taking more restrictions locally on those kinds of activities. Is that an area for further focus going forward?
That's a great point, Mark. And I think, it won't be hard to look back and say, what are the things we wish we'd done differently? I mean, that's the nature of the beast. It's the nature of having an unknown pathogen. It's the nature of science. And I think one of the things that we probably could have done better and need to do better going forward is to target at as narrow a range as possible the people that we're asking to take steps that limit their ability to get income or keep their small business open. The truth is, if problem was isolated to Phoenix and Tucson were fine, which is not the case, or Yuma was fine, then asking people to restrict their travel and allowing businesses to stay open in targeted locations makes a lot of sense, because the virus eventually gets from bigger cities to medium cities to smaller cities. We know that that's going to happen. We don't want to get to the smaller cities at the time when everybody has already felt like they've been inside needlessly. So it takes much more orchestration and much more complexity. That we won't have to do this forever if we do it right. If we do it wrong, unfortunately, I think it prolongs the risk to people who are really most vulnerable and most at risk.
I want to come back to one other focus area, and that's the ones that you highlighted that I mentioned in the opening too, around disparities across racial and ethnic groups, as well as other neighborhoods that have been particularly hard hit because of socioeconomic and close living conditions and the nature of the work there, the essential jobs and the like. That too seems like an area for further focused efforts, not only from a public policy standpoint, but from the standpoint of businesses that rely on these workers and rely on these communities and are facing these challenges at a time of unprecedented attention to Black Lives Matter and concerns about structural racism. Any thoughts about where to go forward with that challenging piece of the pandemic?
Well, if you think about it, there's a lot of people that I talk to who I say, how's the virus going for you, the pandemic? And their answer is fine. I'm spending more time with my family. And, I run in and out of a grocery store and hopefully they wear a mask. But as you know, and as you've talked about, prolonged exposure and particularly indoors is a very different thing than people who are well off and have the ability to isolate and have the ability to not interact as much. And for them, the virus is mysterious. But people getting up every day and having to go to work and interact with the public, and sometimes an uncaring public who's willing to just stand in front of them and talk to them without masks on, which happens all the time, is scaring the crap out of people. Now that happens regardless of skin color. But when you add skin color and look at skin colors even separately, CMS released a report last night or this morning, which showed 4 times the hospitalization rate for Black Americans. Obviously, we know the slope that occurs with older Americans, data just came out on people with autism and developmentally disabled are 2.5 to 3 times more likely to get infected and then more likely to die. So I think this is a kind of moment that calls us out to say what's important to us and who are we. If we feel less at risk because of our age, because of our skin color, because of the amount of money we have, do we start to care less about spreading the virus? Do we start to say, well, I can live my life and those people can just isolate? Or do we say, you know what, we can be responsible for driving down the infection rate to the point where nobody has to socially isolate? I think we're currently failing that test, if you want me to be honest. And nobody cared about my moral judgment. But I think other countries have rallied to this better, and it's not easy. But so far, it appears, and I think it's likely to continue to appear that as people feel safer, they will personally feel safe for themselves and their family. They'll abandon some of these practices a little bit more, and I really hope that that's not the case.
And Andy, I really appreciate your joining us for the comments. We're about to turn to a discussion with the employer community on their steps forward. Given what you just said, any specific advice or key recommendations for employers as they think about what's going on around them, and especially in these hard-hit communities?
I think a lot of what you and I wrote with others in that Open Safely piece is that things are just going to take a new amount of thought to re-engineer. And we need to have, employers just need to rethink everything from who can work at home to people's commutes, to people pushing elevator buttons, to how many people can you have in the office. And, we're at that point in time when best practices haven't quite emerged, but are beginning to emerge. So there's some great documents that are linked to on the Open Safely website. But I expect the state of affairs and the state of the art on these things to keep going and growing. And the employers, part of what you have to do, part of what everybody has to do as an employer or as a business to a customer, you have to add one more thing to your value proposition. Make people feel safe. Communicate and take steps in a way that make people feel safe. If you don't have that as part of your value proposition, I think your business suffers. So it's almost like you need an additional function of somebody who's just thinking about how do we make people feel safe showing up in a call center? Or if we can't, how do we let them work from home? How do we make people feel safe walking into our store or our restaurant? And regardless of what governors or the president allows, ultimately as employers, we have to decide whether or not we want to allow those things. And making those decisions is something that I have confidence that people will want to make, because I think people generally, again, want the right things to happen.
Right. Well, we're going to turn to more discussion of that right now. Andy, thanks again for joining us, and look forward to our continued collaboration. There remains a lot of work ahead on safe reopening. Thanks for all you're doing.
Thanks for all you're doing.
Now I'd like to go to our first panel, which will focus on the back to work strategies for employers opening safely in both higher and lower exposure risk settings. And to join us for this panel, very pleased to have with us Mara Aspinall from Arizona State University and Health Catalyst, where she spearheaded efforts to educate payers and policymakers on a range of topics related to genomics and personalized medicine, but now is focusing extensively on COVID-19 diagnostics and management for businesses. She's based at Arizona State, which has the first and only program dedicated entirely to diagnostics as an independent discipline. Also joined by Rajai Batniji. Sorry, Rajai, sorry, it's a little bit off on the name there, but thank you for joining us. Rajai is the Chief Health Officer at Collective Health, where his work examines the selection of issues related to containing COVID-19. They have a lot of other employer support activities going on at Collective Health, but have really focused on bringing the effective epidemiology and science to employers for reopening. And then Michael Sherman, who's the Chief Medical Officer and Senior Vice President for Health Services at Harvard Pilgrim Healthcare. Michael's been part of innovative approaches to payment and collaboration with employers, care providers, and others to find better models for delivering health services, and that extends to COVID-19 management as well. And Sri Kosaraju, who is from Testing for America now. He's the CEO and head of strategy at Penumbra also, which is a global healthcare company focused on innovative therapies. And at Testing for America, Sri is working with academics, engineers, entrepreneurs from across the broader innovation community to solve COVID-19 testing issues to make it cheaper, easier, and more effective. Very pleased to have all of you with us today. We're going to start out with some opening comments on these topics related to opening safely. And Mara, I'd like to start with you.
Sure. Good morning and good afternoon, everyone. It is a pleasure to be here and so glad that Duke Margolis is focusing and continues to focus on these issues. I'm going to start out with where Andy left off, which is the importance of employers in the midst of this pandemic and the critical piece of people feeling comfortable. And I talk about it as the opening of society before we open up our economy, that people need to be comfortable getting out of their house, spending money, and going to work without fear. It's all about reducing the fear that becomes critical. That being said, as positive as that sounds, we are in a situation now that employers are highly confused. They are getting different information from the federal government than they're getting from their state and local authorities. They have had little ways to communicate with each other. And there's a myriad of different practices that are occurring right now. And one of the frustrations that we all have is there hasn't been enough time to evaluate what is working and what is not working. So with that atmosphere, what you see are people moving very slowly into bringing their employees back in small measures for most of the large employers. Several of the largest employers, and we've seen this publicly, including in Silicon Valley, have just, I don't want to say given up, but they've said, listen, this is too complicated. We're just going to have people working from home until the earliest of January 1st. This may work well for the Google and Facebook and tech companies, but the reality is it does not work at all for manufacturing companies, food providers, hospitality, restaurants, and others. They need to bring people back. So what I would say, and stop with my introduction here, but to say that we need to talk about what are the use cases, what are the best protocols that employers need to use to appropriately test their employees and workers and ensure confidence for the employers themselves, and then by definition for their customers. That to me is the foundational piece that needs to happen, not in 6 months, but over these next 3 months where there's some slowing of the economy during the summer that might be somewhat natural, but to be ready for the largest employers and our educational institutions in the fall. So in summary, bringing confidence to people, publishing and having a broadly useful national set of guidelines on use cases and testing protocols. And Mark, as you know, with ASU and the World Economic Forum, we are launching tomorrow, actually, a very large 5,000 or more survey amongst employers worldwide to understand the current practices and hopefully put together a very succinct set of best practices going forward. We hope to have some data on that before the end of the summer so we can instill some of that confidence in the fall and beyond.
Great. Thanks, Mara. And I do want to come back to some of the next steps to address these variations and the gaps in knowledge. Now, I was planning to go to Rajay next, but Rajay, I think we're having a few issues with your video. We're going to try and fix those so people can actually see you when you're making your remarks in a minute. So instead, I'm going to go next to Michael Sherman for some opening comments from the standpoint of health payers who are working with businesses on exactly these kinds of issues. Michael?
Yeah, thank you, Mark. And it is really good to be here with all of you on this very important topic. And, as we talk about it, I would also add that I'm spending a lot of my time with our leadership and our head of HR because we're looking at the same issues from our lens as an employer. And one of the things that's really interesting about what we've learned, and this gets back to recommendations need to be industry specific, is that we've learned that many of our functions we actually can do virtually very well. So there are a small number as an insurer, there's many more if you're a hospital, but depending on your industry, you may pursue different strategies. That degree of assurance, by the way, and that recognition is important. And it is leading us, for example, to be very gradual in opening because we don't want to make the mistake you're seeing in different parts of the country where everyone has such pandemic fatigue, they're eager to get back in a room together. So I want to point that out. So recommendations need to be industry specific. I also would say that the background prevalence is really important. Everyone is looking for answers and guidance, but what you do in the background prevalence looks like Arizona is different than what you do when it looks like Massachusetts. I know we have a national audience, but I want to call that out as well. And then, what are your business needs? Obviously, if you're a hospital or a meat packing plant, and we have clients who are the first, not the second, fortunately, it may need to different strategies as well. So all that goes into the mix. Testing is obviously a big topic, but aside from that, employers are confused. I agree with Mara in her opening comments. They're looking for answers and they're getting different answers all over the map from different stakeholders. And so many of them are looking to insurers as hopefully a resource that can provide well thought out guidance. And some of the things they're asking about, I won't get into these in detail, but are things like, do you test people coming into the building? Do you take temperatures coming into the building? Again, different thoughts on that. I would remind everyone that there are so many cases of asymptomatic or pre-symptomatic transmission. Some studies show 40 to 50% that's not a foolproof strategy. So while you may choose to do that, it needs to be in addition to other initiatives. We are looking at this as, for example, as an employer, probably not going to have a long line at the door to get in, having people's temperature taken, but we are going to have an attestation. So everyone's going to go to an online symptom checker, which is fairly straightforward, and we're going to ask everyone to attest that they've taken their temperature, that they don't have symptoms, they haven't been exposed. Again, all things that are common sense. In these initial stages, we're advising masks. Now, when you get to it a little more detailed, obviously people who are in private offices may not need masks, those who are more than 6 feet away from others. So a lot that goes into that. And we think that, again, those who have cubicles on aisles versus deeper in may have different expectations. And along with that, obviously, we're recommending, as are many states, that you limit it to 25, 50% of employees, et cetera. That's really a crude measure, understanding it probably has more to do with how your workspace is laid out than any number a priori. Additional questions around elevators, limiting elevators, obviously, conference rooms. I know that many employers are keeping them closed in the first phase and then will open them, but there are logistical questions such as not just do you wear masks in a conference room, or maybe you don't if they're 6 feet apart, but how do you get them cleaned between meetings? Again, not sexy or terribly strategic, but those are questions that employers are facing. The testing issue is probably the area where employers are most confused. And again, for most employers who are not healthcare experts, they just want an answer. And they're confused about many things, including the difference between antigen and antibody testing. We've done webinars for our employers and brokers, and that's probably the greatest area of confusion. At this point, my belief is that the right role for a payer is not to be creating hurdles. We don't want to be getting in the way of care. And that's why we've done other things like removing any cost share for virtual care or paying the same to providers for virtual as in-person care. We're so worried about people not getting access to their physician or other provider that we're trying to remove barriers. And in most cases that I know of, the payers are really pretty much covering fully, not having any limits, not asking questions, et cetera. And that's very appropriate at this time. But I'll also remind the audience that there's a difference between what we normally think of as covered benefits, something that's intended to guide the care that you receive as an individual, whether it's because you were exposed or because you have symptoms or other reasons that it's important for your physician to know. Generally, most benefit designs exclude things like return to work testing for the benefit of the employer, or similarly, colleges that are asking students to get tested. So those generally are excluded by, in terms of the way the policies are written. On the antibody side, again, I don't want to do a deep dive into that, but there was initially some enthusiasm, the idea that if you're immune, there could be immunity certificates, and that would guide how people can behave at work and elsewhere. As I think the audience knows, there's a lot of mixed data coming out, including whether asymptomatic patients have very low levels of antibodies and what percent even last for more than 8 to 12 weeks. So right now, that's a wide open question, and most payers look at antibody testing as for public health reasons, but in most cases, not by, as opposed to by exception to not guiding the care that you receive. At the moment, we don't have any constraints around testing for the virus. And in fact, to be honest, if an employer started doing this tomorrow every time someone walked in the door, which I would not recommend, with the exception perhaps of nursing homes and other specialized cases, we really wouldn't necessarily know it, although it would come to light after a while. Now, people may ask, why don't you just pay for unlimited testing for everyone who needs it, including for all employers? And there's a couple of reasons for that. One, there's basic logistics. Are we going to run out of swabs and tests and capacity for running them if everyone is getting them every week or more or less frequently at work? So there's some real capacity issues, or at least for the moment. Second, there's the issue of cost. And, again, one test is not the issue, but when you start thinking about testing all the workers in the nation frequently on a regular basis, it's material. I do think that we should, once this calms down, still retain a policy where we don't charge the individual for testing. That should never be a barrier to someone getting a test if they think they need it. But there should also be an index for suspicion. You've been exposed, symptoms, et cetera. And if we were just to do it blindly for all employers, the issue is that, again, that budget impact. If you're not paying for it, again, no cost share, then everyone is paying for it in the form of premiums. And again, if you think about doing this regularly, and Mark and others have spoken about this in past webinars, that amount can add up pretty quickly and become material. The other point to keep in mind is that with employers, particularly larger ones, but just generally, in our book, over half are now self-insured. So the idea that, the payers will pay for it doesn't really work for those who are self-insured, because once you make that decision, it means, again, the employers are paying for it, which doesn't really help. And this doesn't really trigger reinsurance anything. So again, in a world of finite resources, we need to strike the right balance between making these tests available for those who need it, but also ensuring that we don't make the entire ecosystem collapse under its own weight. So thank you, and I'll look forward to the Q&A.
And Michael, thanks for teeing up a great set of issues, including ones about cost and the potential use, if any, in this context of antibody testing. So Rajay, good to see you, and glad we got the video working.
Thank you.
I know you've been thinking a lot about these issues, both to address the uncertainty that employers and employees are facing based on the available evidence about what should be done around reopening, and many of these issues around logistics of and appropriate use of especially diagnostic testing. Please let us know what you're thinking.
Yeah, thanks, Mark. Thank you. It's great to be here. And thanks, Michael, for your comments, which I hope to build on. I mean, I think just if you step back, I mean, we went into shelter in place with the assumption that everyone could be infected, and every person that you interacted with may be carrying the virus. And we did it so that we could avoid overwhelming our healthcare systems, but we also did it so that we could buy time to develop testing and contact tracing strategies, time to, as Andy Slavitt said, to frankly learn more about this novel virus and how it spreads and what we can do to prevent its spread. We've learned a lot, and we've actually developed quite a bit in terms of our testing capacity as a country, a lot of it outside of the traditional testing workflows in hospitals. And I think it's up to employers to really take advantage of that. And by employers, I mean all organizations, schools, nonprofits, companies, everyone who's organizing people in the public space to really learn from that. And I think it's on us, all of us as leaders of organizations, to think about what we can do to give people an assurance that as we're reopening, they're going to be safe. And I think for a lot of the country, unfortunately, that assurance is really based on optimism, or it's in some cases just based on wishing that this virus didn't exist anymore or wanting to look past it. And I think that that's not going to work. We're seeing that as in the rising case rates that Mark shared. We're seeing it in the frankly, the exponential growth in some communities. And I think the risk for all of us is that a second shutdown could be more devastating economically as the first, more than the first. And so I think the challenge is, as both Michael and Mara pointed out, is there hasn't really been very clear guidance for organizations of all kinds on what they can do to reliably reduce risk as they reopen. And as everyone has acknowledged, that just created a ton of confusion. I think if you break it down, there's really three categories of actions that any organization can take to reduce risk. The first is to just wait until the key public health indicators for reopening are met. As Mark showed, throughout the country, those indicators were not met, and some organizations are choosing to wait. You see out here in technology companies in the Bay Area where I am, a lot of companies basically saying we're not coming back indefinitely until effectively those key public health indicators for reopening are met. So falling case rates as well as low community prevalence. And so that is a strategy, but that's a strategy that's frankly at this point a luxury to most and outside of the realm of what the vast majority of organizations in the country are really considering, even though it may be the most evidence-based. The second is, well, what can you do to reduce transmission, assuming that some infected people are going to get into the workplace? And this is what I think everyone is doing. It's the area where actually the government has provided some direction. And this has to do with, spacing in the workplace, wearing masks, indoors, and in some outdoor activities. Has to do with increased air recirculation, sanitation, changing the way we eat food or line up for the elevator, as Michael said. And these are actions that are important, but in my view, likely insufficient. And their insufficiency is proven by the organizations that have tried them and failed. You see that in Ford, which reopened, implementing those measures and had to reclose their plants shortly after. You've even seen it in Amazon making headlines recently, having implemented temperature screening and also some workplace measures in their warehouses. And they had a number of deaths in their warehouses that now prompted them to take a testing strategy. And that gets to the third approach, which is how do you keep infected people out of the workplace? And this is also a pretty tricky area to navigate. There's, from a regulatory perspective, been some pretty clear guidance from EEOC permitting actually most of what employers would want to do. But there's also been, frankly, a lot of confusion about the science and the evidence here. I think as evidence of that confusion, there was a Mercer study. Mercer is an HR consulting firm that was released pretty recently that showed that about 26% of employers in the country were planning on taking temperatures on their way in, but only 3% had any strategy for implementing any kind of testing for live virus, so PCR or other antigen testing as part of their return to work and reopening. And if you actually step back and consider the evidence for this, which I've written about and is pretty widely known, but I can summarize briefly. Taking a temperature of an individual, you've got about a 86% or greater chance of missing an infected individual. So we know that from the relatively low rates of fever among infected individuals combined with the relatively high rate of asymptomatic carriers. If you're doing a symptom screen, you can approximately catch half with a high quality symptom screen that includes, some of the more less known symptoms like loss of smell or loss of taste. And if you're testing for live virus, that's the only way to reliably catch the vast majority of infected individuals. Obviously, antibody testing, there's a lag of about a week, which means you'll miss about a third or so of the infectious period. And so really, how do employers think about implementing testing for live virus? Well, very few have their own staff of epidemiologists that would tell them who to test or how often to test. And there hasn't really been clear guidance on this. So as Mark alluded to, one of the key things that we did is create a set of protocols which we've open sourced and they're published on the web that define who to test and how often and what prompts retesting for an employer that's going to use, actual true testing, PCR testing for reducing workplace risk. And I think we have to remember the goal with this is not to bring the risk down to zero. Michael alluded to this. If you tested everybody every day, you might do that, but that isn't the goal for any organization. The goal is to reduce the risk of workplace transmission, sustained workplace transmission, sustained transmission in your stores, sustained transmission in your schools, so that you're not being the source of a epidemic, and that you're doing everything possible to identify that and contain it immediately. And so that's the impetus for the protocols we've created, as well as for the product that we've built, which automates the communications and the retesting and simplifies that workflow of where to get tests. So that's where our focus has been, is how do you make this easy to do? I think a lot of people haven't done the right thing, not because it's expensive, not because it's complicated, but because implementing a testing-based strategy is actually, it requires a level of expertise and level of guidance and clarity that's been absent. And so I hope that can be created. I think Michael, I take issue with one of the points that you made on the cost of testing. I think this is an important point of debate. Right now the cost of your, end-to-end, even kind of at-home test is roughly $100. That if you figure, in a protocolized workplace testing strategy, for your average office worker, they'll, in our kind of quick assessments, you'd expect maybe 2 tests per year. That's a pretty small investment to make for significantly reducing workplace risk. And I think if you were to, bring this to a manufacturing plant where you might be tested monthly, we know at those plants the risk of transmission is even greater than in your average office. Even then, it's probably still a relatively small investment in order to remain open. So I think there could be a debate about this, but clearly, organizations are going to pay for it, and they'll have to make that cost-benefit calculation of, does reopening permanently and reopening sustainably warrant that investment? And what's the cost that organization is willing to bear? So thank you, and look forward to a more discussion on this.
Yeah, thanks, Jay. Great discussion. And you kind of highlighted with this virus the challenge of asymptomatic transmission and the limited impact alone, at least, of stuff like temperature checks, symptom checks, and the like, and the importance of testing and the costs associated with it. So I'd like to turn to Sri. Sri, you've been doing a lot of work lately, and maybe you could tell the audience a little bit about it, along with your comments, to try to improve the sensitivity, the specificity, the reliability, the ease of those tests, and bring down their costs to help with exactly the kinds of challenges in creating a safe workplace that we've been talking about. Please go ahead.
Great. Thanks, Mark. And thanks for Alexandria and Duke Margolis to put this on. I think it's important to have this kind of collaboration to find our way forward. Testing for America is a group of today 15 volunteers that are operating in this nonprofit, jumping in to help. And some come from the industry and know the problem well, and some, like me, come at it from outside the industry or from a different profession, but are really just trying to do what everyone on this call are doing, which is trying to figure out how we can help. I'll tell you a little bit about sort of 3 areas we're focused on and some observations, and I think they're fairly consistent to the other panelists on this session. The first area of focus is around the message of why testing is important. We're moving from a phase where testing has been looked at primarily, within hospitals for sick patients, and now we're having a discussion of what is the application of testing as we reopen within businesses, within schools. How should it be applied? And it's almost helpful to me to think about it as almost a new phase, and testing will look different in this new phase. And I think we're starting to see some of the data to help us understand things like asymptomatic infection and spread, and how can testing be utilized, and why will it be important in this next phase of reopening. The second area, which Mark, you alluded to, that we're focused on is around the science and technology. I think, as I've dove into this newly and understood it, it's very much an engineering and logistics problem that we're trying to solve. We're taking an existing set of tests that were used for clinical purposes in hospitals, and now thinking about, can we scale that to a much wider and broader audience. Naturally, things need to change. We need to do some things around the current tests, the RT-qPCR tests, to allow them to scale with our, with that existing infrastructure. We need to add other new technologies that exist today, but potentially repurpose them so that we can add significantly more net new testing capacity. And it will not only be in sort of the lab environment, but it'll also be in some of the point of care settings as well. There's a variety of different demographics, locations, types of businesses, organizations, and they're all going to need different solutions. It's not a one size fits all. But the one message I'd say in the science and technology that I think is important, for us to convey and for everyone to appreciate is the path to that second phase of testing, I think, is very much in sight. The ability to have the capacity we need that's accurate, that's cost effective, and it's rapid, I think is very much in our sights. And I think, that may have been a detractor for why people didn't move down the path of testing. But I'd say from academia who are focused on this, from the testing industry who are also in this every day, and from entrepreneurs coming at it from outside industries who've dove into these problems, which are, as I mentioned, engineering and logistics problems, they're all solvable. It's a question of how fast can we solve it? And Mark, to your next session and panel, maybe there's some things that can be done to help accelerate, our speed to that with other things that public policy can do to help us. The third area that we're focused is around the organizations, employers, universities, schools, and how do we help them find the answers they need on how do they implement their own testing strategies. And I think, leaders who do this first, and we like to think of it as pilots, will be, I think, extremely important in showing that way forward for a lot of folks to follow. As we talk to a lot of leaders in business, there's usually 3 reasons they give of why they're not exploring a testing strategy for their employees or constituents. One, they're not sure if it has any benefit versus, mask wearing and social distancing. 2, they're worried about the complexity of putting it in place. And 3, they're worried about the cost. As I just said, I think we're fairly confident we're gaining the data to understand why it's important. 2, I think with more visibility, people can understand how to do it. And there's a lot of groups out there helping with that. And 3, the cost will come down. And I think as we scale this, it's almost circular. If you have growing demand, it can help the manufacturers scale up more rapidly, which will allow, inherently the cost to come down to drive more demand. So it's in effect a circular reference. But I think I'll just end my comments by saying I'm pretty encouraged we're moving towards having visibility to get there. And now it's, I think, just doing the work on what are the forms that we can help accelerate this to get there faster. Thanks, Mark.
Great. Thank you all for the comments. I appreciate the points about innovation helping here and maybe changing views about testing. I did want to say, because we got a couple of questions from some of our participants. You all, including Sheree, in your last comments, I think are mainly talking about testing for the presence of a viral infection. So the PCR testing, the antigen testing at point of care, those varieties of tests for active infection of people who might be able to transmit and therefore create a less safe workplace. You all mentioned antibody testing, and Michael talked about, at least currently, the technology suggesting that's useful for understanding, say, prevalence in a community, but maybe not a key part of a strategy for employers. Do people generally agree with that, or are there any comments you'd like to make about the role of antibody testing in the near foreseeable future in employer strategies?
Okay.
Go ahead.
Go ahead.
You go, and then I'll go.
Sure thing. I get asked about antibody testing all the time by organizations, and I think there's a pretty clear consensus in the scientific community about the relative lack of utility of the form of testing for return to work and workplace risk reduction strategies. That's not really matched by the consensus in the operators. And so there's still a lot of questions about it and a lot of interest in antibody testing. And maybe it has a role in a very low prevalence environment, but for the most part, it doesn't really have a role to play in return to work strategies. And the main reason for that is the time it takes to develop antibodies. So even if the sensitivity and specificity of the tests were better than they are and they improved, it's still hard to get around the fact that you're not going to develop the antibodies in most cases for about a week or so from the time that you're infected. And that time to having positive antibodies itself reduces the value of those tests.
Mara?
While I agree with that broadly, I think with Rajay's comment, I would have sort of a different take on it. I also agree that the antibody tests are not useful on an individual basis and potentially most useful on a population health basis. But two comments. One is, I'm not even sure today it's useful on a population health basis until we start talking very seriously about a vaccine. And we need to understand the antibody status. But my worry about it is actually in low prevalence communities with the relatively high possibility of a false positive. Even if you have a fairly accurate test with only 97% specificity, 100% sensitivity, that 3% false positive becomes a critical issue in a community like Tucson. I appreciate Andy mentioned what's happening in Arizona, where a recent University of Arizona work on an antibody test showed even with first responders, after 6,000 tests, we had a prevalence rate of 1.26% positive. If we round that up to 1.5%, what that translates into is the false positive could be as much as 64% of the given positives of the antibody tests. So I think that if you're going to implement an antibody test and use it in any way in the workplace, it's got to be one that has the Emory approach, which is a reflex test for all positives, and doing a second antibody test to ensure that it is truly an accurate, true positive. So I think the combination of what Michael said, many payers are not paying for these tests, or if they are, they're only paying for one, says to me that we should use our precious resources and time on more smart testing on a viral basis and not on an antibody basis.
A lot of room for further development there, which I want to come back to if we have time. We did get a couple of comments about some specific settings. So Mike, I'm going to go to you for one of these. Healthcare settings. So you talked about this from the standpoint of health insurer, but you're also working with a lot of healthcare providers that are, on the one hand, trying to reopen safely and get people back to using needed so-called elective services that have been severely depressed during the early phases of this pandemic. But on the other hand, with continued community spread and some areas entering phases of exponential spread again, they got to be worried about their hospital capacity and the like, and also patients, especially in higher risk groups, are understandably nervous. Now, you've been involved in a lot of work with healthcare organizations trying to move some of those services outside of the hospital, more community-based. Do you, home services, telemedicine, et cetera, do you see that continuing as a part of the management of this pandemic from a healthcare reopening standpoint? Is it also just different nature of work for the healthcare providers?
No, I actually think that's a great question. And it is an area that we have seen a lot of movement, and I think it will persist. I think it'll persist, first of all, until that time and date when we have a vaccine. But even at that point, people are learning, people being physicians and patients, that much of what happens in a visit can happen virtually with really good results in meeting the needs. Again, you may need follow-up PFTs or other things for an asthmatic, et cetera, but a lot can be managed. When you look at that together with the move away from fee-for-service based care, which has been a long-term trend anyway, toward paying in different ways for outcomes, it means that a lot of the barriers to virtual care, a lot of reimbursement and others, and comfort with technology, et cetera, will go away. So I think we're seeing some permanent changes. In the near term, though, absolutely seeing movement to more safe, more effective better sites of care. So an example would be moving infusions for some medications, probably not toxic chemo, but maybe if it's IVIG or Remicade, it's been shown that that can be delivered safely at home for many people. And there's been resistance in the past in terms of the initiatives that are coming out. Well, all of a sudden, there's a lot more interest from patients and providers in doing more of that. So yes, absolutely doing what we can to facilitate through changes in how we pay and making it easier for all stakeholders, but absolutely see that continuing and accelerating.
And also got questions about universities reopening. So complex organization with a lot of young people, a lot of people who typically move in and out, hard to maintain a bubble and a contained environment. I know several of you have been working with universities. Sri, Mara, do you want to take that one?
Yeah, and Mara will have more to add to this, but it's obviously top of mind for all of us, schools. I have 2 young children, and we're looking at August and how will they come back. Universities are typically where I think a lot of us are focused. There's some students already back on campuses, athletes and other school programs, and we're starting to see the articles about spread within some of those early return to campus type students, which is highly concerning. There's screening tools that a lot of folks are looking at, app-based things that can help with quick assessment of condition. I think a lot of universities are thinking about the right protocols to put in place if they do have active infection. I think testing still is broadly debated. It is like employers, I'd say, a lot of folks still trying to figure out how to employ it, how to pay for it. But I do think it is incredibly important that we get it right. I think a lot of universities are moving towards the momentum of getting people back on campus, but you have some schools that are isolated in their own, communities, and some that are part of broader communities, and they pose tremendous challenges. So I think each one is going to be different in how they look to their solutions. But obviously it's the more imminent thing that I think all of us are focused on.
Yeah, and Mara, even on a limited basis, some of the universities that have tried to reopen just for their athletic programs are seeing outbreaks. Your thoughts on this?
Yeah, I think that the universities will use a very simple test, trace, and treat approach. I think the biggest thing that I have seen, well, the 2 biggest things that I have seen is, one, for them allocating rooming space for students who are sick, who can go somewhere where they have the ability to recover in an isolated place. This is something universities have never done, and many have had challenges with housing, but they're finding ways to do that. Secondly, I believe that universities will be amongst the most aggressive in contact tracing. And you've seen a couple of universities say, we're going to provide everything on this university, do not go outside of our walls, so they can more effectively contact trace. And then lastly, in terms of testing, I think it's a mixed bag. Some don't have the resources in the current environment to test everyone, so they're going to go with a calculated bet that most young people, even if they get the disease, will not be very aggressively affected. I think lastly, the work in terms of how much of the classroom experience will be direct and how much will be Zoom. I'm a fan of the Yuri Alon approach, which is 4 days on, 10 days off. A lot of universities and businesses are talking about Monday, Wednesday, Friday. I see that as the highest risk perspective. If you go with the Yuri Alon approach, you have 4 days that people are together in some sort of cohort. If they get sick, they are most likely to get sick in the 10 days after those 4 days. And then they can self-isolate and then bring back another cohort in 4 days. So with several universities, I'm talking to them about implementing that kind of a schedule.
Interesting, and it's a great discussion. We're about out of time. Is there any final closing thoughts on this topic? And Mara, you touched on it. So we've talked a lot about what employers can do within the employment context, but keep in mind that their workers do go home, their students do go outside the workplace, and so home settings, transportation, the kinds of things that Andy mentioned, where we're seeing a lot of outbreaks happening and impacting businesses are having an effect. And this may be just any quick thoughts on this topic. I know it's a tough one, and maybe one back to Sri's comments where there needs to be more public sector collaboration with employers. Rajay, do you want to start? Rajay, are you?
Yeah, I mean, sure. I think, the high level thought is, and I think Andy said it. Okay.
Yeah.
The quick thought from Andy was, he said, to make people feel safe. I think that that's probably not enough. You can't just make people feel safe. You need to actually make them safer. And that's where, in my view, for whether you're at a university or whether you're at a company, can you actually communicate to your people what you're doing and how it actually demonstrably reduces their risk? And those strategies, I think, need to be clearly communicated and laid out. And I think hopefully we can get better public guidance on that. But in the absence of that, I think we can all be transparent about what we're doing and how it reduces risk.
Thank you. And Sri?
Yeah, one thing I totally agree with the comments. It's most businesses now, we're talking about stakeholders rather than shareholders in terms of who you serve. And your employees right now, with all the things that are going on in the world, there's safety, social equality. This is I think an unprecedented time where companies and leadership and boards are going to be focused a lot on their employees and what they can be doing, to support them. And so around this topic, I would say it's education, it's collaboration with others to try to figure this out, to make sure you have all the information. It's managing your risk on the downside. It's continuing your operations. Yes, it may come with more cost, but I've spoken to a lot of large public investors, and all of them, not one, has told me that they would not agree with a company that took more cost on to protect their business. So I think there's all the support in the world to do this. So any of the barriers that we see of why we shouldn't be doing it, I think should be challenged, because I think we're solving all of them.
Thanks. And Michael?
Yeah, I would echo everything that's been repeated previously and remind everyone that we're talking a lot about employers as corporate entities. I deal a lot with heads of HR and other leaders, but the rank and file, I would remind everyone, people are scared. They're nervous. And we ask what they're nervous about. They're nervous about things like being pushed to go back to work prematurely. What if they have risk factors? What if they live with someone who's high risk? So all that needs to be factored into account. And I do believe when all is said and done, this is going to create impressions that are long lasting, both good and bad. So again, this is a chance to show what we're made of and what our cultures are about. And again, I'm not talking about positions like being a waiter or working in a store where you kind of have to be there. But for many industries, as we know, there are choices. And so there is an opportunity to provide reassurance. And we've done this for our own employees, that anyone who is not comfortable, either because they have a risk factor or have a relative or just perceive that, won't be pushed to go back prematurely till they're comfortable.
Great, thanks. And Mara, I know you're planning some further work on exactly these topics, hopefully some in collaboration with us at Duke Margolis and the broader Rockefeller Foundation efforts in this space.
Yes, very much so. For me, it's all about smart testing, and that we have to be working with public and private sector partnerships. And when I talk about partnerships, it may be that a private sector employer takes care of their employees, but also takes care of the folks in their community who may not be employees. We are planning this launch of a broad survey to understand by industry what people are doing now. We will update that on a quarterly basis throughout the next year and get data on what is happening today, what needs to happen in the future, and ultimately what the results of that are, so we can share that data with all employers to understand what the best practices are. So look forward to updating that, Mark, with your team in about 3 months.
Well, more to come. So Mara, Rajay, Michael, Sri, thank you all very much for an excellent discussion. I look forward to staying in touch about these challenging but critical issues for safely reopening and managing the pandemic. Thank you very much. And would like to turn now to the public sector side of this. We're going to talk now about some of the public health considerations, ones that came up just in this the last few minutes of this discussion, and considerations for vulnerable populations, hard-hit neighborhoods, areas where government action is likely to be essential to augment private sector efforts and to get to a safer reopening. And for this, very pleased to be joined by another truly distinguished panel, Rob Califf from Google and Verily, where he leads health policy for the Alphabet Health subsidiaries there. He served as the founding director of the Duke Clinical Research Institute, also former commissioner of the Food and Drug Administration, one of my good friends and close colleagues. Rob, thanks for joining us. And then Caitlin Rivers from the Johns Hopkins Center for Health Security, where she's a senior scholar and assistant professor in the Department of Environmental Health and Engineering. And she's doing some highly relevant research on epidemic preparedness and response, been widely cited and influential in pandemic response. Also joined by Robin Stone from Leading Age, who's a leading authority on aging and long-term services and support policy. She's the Senior Vice President of Research at Leading Age, co-director of the Leading Age Long-Term Services and Support Center at UMass. We've done a lot of work, especially related to this highest risk population that accounts for such a large share of deaths and burden of disease, older individuals with significant disabilities. And Raj Shah, who as the president of the Rockefeller Foundation has done a tremendous amount of work on global health, promoting the well-being of humanity around the world. He did that at USAID administrator and other important jobs prior to this. I would say that the Rockefeller focus has been on dealing with public health threats throughout the world, including in sub-Saharan Africa. And Raj is going to talk a bit about the refocus that the foundation has had in dealing with pandemic threats right here at home in the United States, and some of the responses there too that involve bringing the public and private sectors together. But I'd like to start with Rob, and I know, Rob, you have to depart from the webinar a few minutes early. Like to just hear your opening comments on this topic. I know Google and Verily are trying to do some, we call it unique work at this very important interface between the private sector and individuals and the public health responses around making it easier to do safe and confidential, or as confidential as possible, contact tracing, which is an area where we definitely need more progress in the United States, but I know you've got a lot of other activities going on related to the topics we're discussing today.
Yeah, thanks, Mark. It's great to be with you. I hope I can stay on as long as possible here, because I think the discussion should be fascinating with the other panelists. And I'll try to quickly just make a few points. I've been privileged to sort of look at a broad expanse of the topic that you're talking about, and I'll mention 3 levels that we're working with. The first is community testing, and we were asked by the Governor's Office of California to help out very early on in the pandemic, set up community testing, and have now expanded it to over 150 places around the country, with a big focus on true community testing. That is, places where people can come from a variety of sources, and a mobile unit, which has turned out, I think, to be a really important part of what we do. Because if there's an outbreak, let's say at a nursing home, or there's a community where a hotspot appears to be occurring, the ability to go to where the people are as opposed to having them find a testing site is really important. The second area is the employers, and there was some press around this just this week, but we do have a product designed to help employers return employees safely to work. And that has been fascinating because employers, as you've already discussed, range from small enterprises to mega corporations to universities with all of their complexity. And then the third area is contact tracing and related activities. I think everyone's familiar with the Apple Google app that's approach that's been developed, but there's an essential link that needs to be made through public health agencies to apps that actually conduct the contact tracing. I think it's fair to say we're not nearly far enough along there as we need to be as a society. I think the view going into this is that Apple and Google both felt that most people don't want Apple and Google tracing them around. And so we need third parties working through public health authorities to work with it. That's evolving. There are a number of players in this game trying to work on successful approaches, but I think we have a long way to go. And I want to make two sort of overarching takeaways that I've gotten from this. The first is that we have such a fragmented system in the US that it's really kind of pathetic. We have so many smart people who can deal with data, and I think another panelist already made this point. We don't have very good data. So we have a lot of testing now. The testing is wrapped up, but the testing is not very smart because it's not integrated with other health data to try to see that the people who need testing the most get tested and the follow-up occurs. And then the second is just a general observation. None of this is going to work until we get rates down in the community. For example, if you're an employer and the rate is at a pretty high level in the community, the odds that your employee gets infected at work is lower than the odds the person will get infected at home. And so all these systems are really not going to work until we socially distance, wear masks, and avoid big events that can lead to super spreaders having a big impact. Then I think a lot of this stuff could work, and it ought to be driven by the kinds of data that we're very capable of putting together, but we just haven't done it yet.
Great. Rob, thanks for those comments. A number of important topics there that I hope we can come back to. And I'll start with the last one. And next up is Caitlin Rivers. And Caitlin, I know you've been thinking about exactly these sorts of topics with the evidence-based guidance that you've been developing nationally and some projects that we've done together on testing and tracing containment guidance for states, for mayors. And it does get to the issue that Rob just mentioned. It's hard to get containment and have safe employment spaces with outbreaks in hotspots like vulnerable communities and some of these other settings that Rob's just described. Maybe some opening thoughts from you?
Yeah, sure. Rob's remarks, I think, really got to the heart of my passion as it relates to this outbreak, which is that we need great just data to make great decisions. And I think at this point in the outbreak, we should be able to have the kind of data to better understand where are people getting infected, especially in the setting where a lot of us are staying home. Is it at home? And if so, that would point to the need for example, voluntary isolation and quarantine facilities so that people can recover safely away from their homes. Is it at work because they're essential workers? And if so, that points to a need for better occupational supports and protections for workers, like maybe an upgrade to personal protective equipment. We need that kind of data. And I want to focus the rest of my remarks on vulnerable populations in particular, because they have been disproportionately hard hit. But I think the question about where people are getting infected and how that relates to our data needs is very centrally linked to the disproportionate impacts on vulnerable populations, because we need a better understanding of why they are at greater risk. We know there are systemic issues, but there are likely reasons that are more easily intervened upon in the timeline that would be required in this outbreak to make changes. And I think it is data that would allow us to kind of identify those points of intervention. So I think we all know by now that it is testing, tracing, and isolation that would allow us to regain control of our outbreak. And we do need to wait until the levels of transmission in the community are reduced to a point where those interventions become feasible. But nonetheless, at some point, I expect that they will, and it will be like an elevator where transmission is coming down, tracing will come up, and at that point, we can make a handoff. So thinking specifically about vulnerable communities, it stands to reason that because a disproportionate amount of transmission is happening in particularly communities where people of color are living, testing needs to be accessible to those communities. And I think it requires the support of the federal government and to some extent the state government to make sure that the resources are available in those communities to bring the testing there and to make sure that those people have access to the testing and are not having to travel, for example, large distances to access testing. We really need to make sure that our testing is centered in communities that are hard hit. Tracing. Public health departments in low income and communities of color are even more gravely underfunded than public health as a whole. And we know that as a whole, public health is generally underfunded. And so I think there's an important role of Congress in particular to direct resources to these public health departments that are particularly underfunded and that serve communities that have been hard hit. And that will allow them to scale up contact tracing, to scale up support services for the community, and to make sure that the resources and the infrastructure are in place to manage the epidemic locally in ways that are contextually appropriate. And finally, isolation. And quarantine. We know there are a lot of barriers that can prevent people from isolating or quarantining successfully, and it should be the role of public health to make sure that the resources are available to support people through that process. That is a large part of the reason why contact tracers follow up with people every day while they are in quarantine and isolation, to make sure that they have the things that they need in order to stay at home successfully. That could be medications, it could be food, it could be housing support. These are really important resources that people need in order to stay home successfully. And it is that intervention of staying home that breaks chains of transmission. And so it's so important that we get it right. Also, paid sick leave is huge. We need people to feel that the incentives are aligned for them to be able to identify that they need to stay home or to comply with stay-at-home orders and to do that successfully. And I think paid sick leave is something that we've always recognized is an important component of public health, but I think it's really come to the fore in managing this outbreak. And I would like to see a continued emphasis on providing paid sick leave and supporting businesses to be able to provide that paid sick leave. And just to end with some numbers that we've actually, let me back up just one second. Underpinning those three pillars of testing, tracing, and isolation is community engagement. And I think particularly for marginalized communities and communities that are historically underserved by public health and medicine, it is important at every step that we find ways to engage community leaders, community members to identify what they need in order to manage the epidemic successfully and how we can better support them through that. And that's a piece that I don't hear a lot about, but I think it's critically important to make sure that the interventions that we introduce are well tailored to the communities that we're serving and that we are meeting not just the needs that we have identified for them, but that they have identified for themselves. And I think I'll leave it there.
Great, and I think that's a great point to end on, and one that does obviously have some close connections to the employers in each of these communities and where their workers are living. I would like to go now to Robin. And Robin, we talked about some hard hit communities, probably none harder hit than elderly and frail individuals in congregate living facilities, nursing homes, assisted living, and the like. The numbers early on, first phase of this outbreak, were really astounding. How much of the deaths and hospitalizations came from these settings. It seems like some of those numbers are getting better now as we've taken more steps to intervene. But can you give us a sense of where we are with what has been a huge part of the deaths and hospital burdens with the pandemic?
Well, thank you so much for this, and thank you for having this session. I've learned a lot from the first part of this, and you're hitting my passion on the second part of this. I actually have a doctorate in public health. My background is in public health, and I've worked in aging for 46 years. I have been distraught, to say the least, by the failure of our public health system to deal with the most dramatic problems in the populations, elderly, people of color, both of which are in my sector. We are at the epicenter of all of this. Leading Age represents the full continuum of aging services providers, from nursing homes, assisted living, home care, home health care, and about a third of our membership are low-income housing properties, affordable housing in very low-income neighborhoods. So not only do we have the high-risk populations living in our various settings, but we also have the people who are caring for these people the most high risk. And that is a recipe for disaster. I don't know how many of you have read so many articles blaming the nursing homes for this epidemic in these settings. And I will tell you, as no apologist for a nursing home, the latest studies show that the deaths and the cases were associated with location, the size of the nursing home, and whether the resident was African American. Had nothing to do with quality measures, nothing to do with prior infection control deficiencies. This is a public health problem that needs attention in the future. Caitlin talked about the fact that we have such low investment in public health. In late January, I was in Singapore when this broke out in Singapore. Right away, as we were in meetings, the physicians and the public health people were leaving our meeting to go out into the community. There was no distinction between the medical care system and public health. They have an extremely robust public health system in Singapore. We have nothing like that in the United States. The amount of resources that are put into our public health system is a complete disaster, and the federal government and state governments need to start turning this around. And then there needs to be collaboration. As soon as we saw the outbreak in Washington State, and we saw that that nursing home was a hotspot, we should have been there immediately with surveillance, with testing, with contact tracing, with understanding that the frontline workers were going and working in 5 or 6 different places at the same time. No wonder this epidemic was spreading like wildfire, and yet nothing happened. And not until 2 months later did we start to see some investment in these hotspots in these communities around the country, whether it was a nursing home, assisted living, or in Massachusetts, a lot of congregate housing, where finally the public health departments were able to come together with the providers to actually start to do the kind of testing and social isolation and cohorting that is essential for us to bring these numbers down. I am really frightened, and our whole organization is afraid of this reopening, because we were going to see staff leaving the buildings and going back out into the community and bringing this right back into these spaces. We're starting to see nursing homes opening up with visitation from families who are angry and not surprising angry that they have not been able to see their loved ones in 3 months. But this has to be recognized as a public health debacle that we can do something about. And I believe it is the responsibility of the federal government and the state government to start to redistribute dollars into a public health sector that has the competence to understand how to deal with these high-risk populations, how to do early surveillance, and how to do maintenance over time. And right now, we do not see that happening at all. So I love the fact that we have an opportunity for all of us here to sit and talk about this, but this is really a call to action for us at Leading Age. We are seeing deaths and cases every day. We see new hotspots popping up all over the country. And this is not going to go away anytime soon. We still remain in the epicenter as everything is reopening. So to me, it's a call for action for the United States. The CDC, which has been completely underfunded, has no aging program whatsoever. CDC, CMS, the states, locales need to be working together with the private sector to really shore up a public health system that is going to continue to address problems of very, very high-risk people.
Great. Thanks very much, Robin. Thanks for all you're doing at the as you said, right at the epicenter of the pandemic. And Raj, I can't think of a better introduction for you than the notion of a call to action to address these serious underlying causes of the continuing outbreaks in the United States. Maybe you talk a little bit about what the foundation is doing, and then your thoughts for this panel.
Sure. Thank you, Mark. First, let me just thank you, because the foundation wouldn't be doing half of what we are doing if it weren't for your really significant commitment of time and leadership to our collective and joint effort. And I think it just shows that, it seems like outside of Washington today, we can get people together who've had a variety of different experiences, who are in the public and private sector. Mark and I get to work with folks from science and industry who have added a lot of value together to craft as best as we can a national testing action plan for America. And the Rockefeller Foundation, together with a group of experts, made an attempt to put together an action plan a few months ago because we didn't think the federal government was succeeding in doing so. And at the time, what we called for, America was doing maybe 700,000 tests a week. We called for hitting an initial target of 3 million tests a week. We then proposed that we go from 3 to 30 million tests a week by the fall. And we called for $100 billion public sector federal government investment in testing, most of the money for the states. I'm proud that the first CARES Act included 25 billion. We've been able to find about 11 of it, of the 25, that is allocated to states. And so together with the Duke Margolis Center and so many others, we are working to help the states, take in and then use those resources for really exactly what Robin and Caitlin highlighted, testing plans and strategies that accelerate testing, tracing, and what we learned to call wraparound services, but food, medical support, and isolation support, which I wouldn't have thought of as a core element of a testing program, but whether you're in Navajo Nation or in a lower income part of Queens in New York City, that is what people need, and that's what they're not getting. And so I'm excited that America got up to north of now 3 million tests a week. But I am very, very concerned that we're not on path to get to 30 million. And, we should have a bit of a discussion as to why 30 million tests a week remains an extraordinarily important target, not really a stretch goal, kind of a floor, as Mark has kind of taught me. But, the reality is from October to February, if you have 100 million episodes of symptoms relating to the common cold in the American population, all of that will present like COVID-19. And so, you in order to keep schools open, in order to keep universities viable, in order to keep essential businesses going, and in order to support what now looks to be a pretty firm political commitment to reopening, even Democratic governors who I think got a lot of credit for clamping down and building the public-private partnerships that Rob talked about, have pretty publicly committed to really leaning into staying open. I think that puts even more pressure on testing, on tracing, on isolation, and on doing that in vulnerable communities. The one thing when Caitlin and Robin spoke, I couldn't help but think about is the federal guidelines still call for testing largely for symptomatic populations. That's right. And I think the bridge we need to cross together is creating protocols for testing asymptomatic populations. I can understand that companies that have resources will go ahead and do that just to stay open and viable. But nursing homes that have, high minority populations, for example, I would hope that there's an understanding that they should probably, and I'm not the expert, so this could be wrong, but it seems to me like, you've just got to test anyone who gets near that kind of a facility and be very, very careful about it. And the fact that President Trump only sees and meets with people who've been tested is not necessarily an epidemiological model, but it is sort of the obvious reality that if you're the president of the United States or an NBA player, you're getting tested because a lot rides on your survival. Well, we should treat all Americans to some extent like that. And frankly, if we can't treat all Americans, we should treat high risk and vulnerable populations, which are minority populations, which are elderly populations, and which are elderly workers. Essential workers. And I remain distraught. I don't know if others, are more. I'm just shocked and surprised. I keep clicking on the CDC website, expecting kind of some new guidance, because yes, the Rockefeller Foundation will step into the void as best we can, and we'll do it by relying on experts like Mark and many of you. But at the end of the day, it seems to me like you just have to have a bolder federal approach, and all of the public statements imply that we're going the other way. Last thing I'll just say is at the end of the day, I align myself with the fact that the public sector needs resources to do this. We've put somewhere between $3 and $5 trillion into the U.S. economy, depending on how you score Fed Reserve actions. I don't take issue with any of that. I just think a more significant allocation of it to the actual crisis we're facing, which is a pandemic health crisis, would be more effective. And so there's $75 billion in the HEROES Act, and I hope whatever passes Congress, and if any of you have influence in this context, I hope you will repeat to those who make these decisions, the $75 billion for testing, tracing, and isolation that would go to the states in the next stimulus bill is a very, very modest allocation to actually hit the problem head on, as opposed to just deal with the symptoms of it. So that's just to get some thinking going. But thank you, Mark, for your leadership, and thank you to all of you, public and private, for just jumping in and making this our shared challenge.
Yeah, Raj, a great way to start off this discussion. And so I'd like to go to Robin because this picks up on, I think, a common theme across the panel around, we kind of know what to do, community engagement, testing, tracing, isolation, and quarantine, with a recognition of what's going on in the community, not just in the workplace, as Robin said. But Robin, to maybe put your energy in a bit more, I might say you're an optimist by nature, I think, but what are we seeing that's working in the communities that you're dealing with, that if there were this additional federal support and ability to bring it together at the federal, state level, and working with employers and private sector, what is it that we're trying to expand? Have you seen any success stories yet?
Yeah, we have. I mean, we have seen incredible, number one, we've seen incredible local public health departments working together with providers at the local level to make sure that we get testing and contact tracing happening for not just symptomatic, but asymptomatic folks, particularly our front line in our sector. Because remember, our front line is primarily people of color. The certified nursing assistants, the home care aides, these folks are people of color. A quarter to a third of them are immigrants. These are folks who leave and go back into their communities. So it's their workplace as well as their environment that has to be addressed. So this community approach to understanding that this sector is not just a care sector, but it's a community sector. The entire set of workers as well as the people who are getting cared for need to be tested. We have examples of our organizations that have actually set up hotels for social isolating staff who need to be kept out, who need to be quarantined. We have a lot of examples of wraparound services. Rajiv, you talked about the wraparound services. These folks they have food insecurity, they have economic insecurity, they have transportation insecurity. We have wraparound services that have been set up together between the public health departments and the providers. There's a lot of this that's going on. The problem is it is so inconsistent. We still have trouble getting PPE in many of our places, and it's better in a nursing home than it is in home care. So think about this. We've got people now being sent back out of the hospital into the community. Home health is starting to grow again, as is home care. And we have these folks going into these communities without the kind of support that they need. So I think the examples are at the local level, strong collaboration, particularly between public health and the providers, and by the way, private labs. A lot of our organizations have turned to private labs. The ones that have more resources, who are able to actually pay private labs to get these tests in, have been able to do this a lot quicker. But of course, that's not all organizations can do that. So it's the inconsistency, I think, that's the problem. We actually know what to do. And Caitlin has done a fantastic job at Johns Hopkins of sort of setting up a framework. But we need the infrastructure to help make that happen across the country.
And I want to go to Caitlin in a minute, but Rob, I want to make sure to get you in while you're with us. So you've heard a bit more from the other perspectives, importance of data to support the kinds of models that Robin just described. Do you see a path to getting there? I'm sure this relates to much of the Google and Verily work.
Well, I think absent a federal effort of the magnitude that's needed, and I hate to admit it, but I share Raj's pessimism right now. I think the horse is out of the barn again with the reopening.
Yeah.
And while people have declared they're going to do it, the numbers are not looking good in a number of states. And I don't know how you rein that back in unless you rein in the freedoms that people have that they're so intent on having. So in the absence of that, it's going to take a private consortium network that I hope can ally with county and state public health officials. And I just want to keep stressing this. Unless we get the businesses and the universities and communities really working in sync with the public health officials, it's going to be very hard to make this work in the absence of a big federal program, which I don't see happening. But the data systems we have now are entirely flexible enough to make this happen if we can solve the cultural problems. Robin made the point, I know Caitlin's done a lot of work on this. The American public health system is really an amazing patchwork. I learned about this as FDA commissioner, but let me tell you, I'm experiencing it firsthand now with county officials who don't have to do what state officials say and state officials that don't have to do what federal officials say. But we need to use our data and our private system to link these people together so that they can do their jobs better. And I am enthusiastic that we can make substantial progress in the near future. Also, just one other final comment before I go. I agree with Robin that we basically know what to do, but exactly how to test asymptomatic people, how often it should be done, how to interpret the tests in low prevalence communities, I think there's a lot to learn. I'm very enthusiastic. We have a number of modelers working on modeling schemes, and as we begin to feed the models with data, and this gets back to your previous panel, if we link employers together by type of employment, like nursing home, architectural firm, universities, I think we can come up with standards of care and practice that can be very quantitative, would be the lowest possible cost for the best possible outcome. That's going to have to come from the private sector. Again, I say, I hope linked with the public. So I'm going to have to go, but I really appreciate the chance to participate in this.
Rob, thanks. I appreciate it. Really appreciate the way this call to action is coming together. It does seem daunting, but I know Caitlin's going to help us articulate how to get there. So, Caitlin, you gave the analogy earlier of the elevator coming down and meeting the testing, tracing, and isolation containment capabilities, especially in these higher risk communities and settings. Again, it's workplace, it's community, it's transportation. It all fits together. You mentioned that coming up. Where I see it, I mean, the elevator is going up, not down, in many of these states. In some cases, going up exponentially. But I think the approach that we've outlined here, combining data and increased testing, tracing, and an isolation infrastructure, supported by community engagement and maybe focusing on some of these high-risk settings. I mean, it seems like the right overall direction to go. Maybe you could expand a little bit on how we can actually get there together.
Yeah, I do. I agree that the steps we need to take are largely outlined, and Congress has allocated a substantial amount of money towards making it happen. I think for me, the devil's in the details, and it's the implementation where a lot of state and local officials are struggling because they do a whole lot on very little, and adding in this new set of responsibilities in a time of immense crisis, much of which they are living through as community members as well. You know, they are facing their own challenges at home and with their families. So having to take on this added burden of responding to a pandemic without the kind of federal support that I would have recommended, I think is extraordinarily difficult. But the point that I always try to make is that it's not too late. All of the things that I recommended in March around testing and tracing and isolation, those options are still available to us. And although it feels like a lot of the political will around making those happen and moving that mountain has faded away, that option really still is available to us. And I think it's important that we make that point and that we realize that continuously, that every day that goes by that we do not devote the kind of support and resources to implementing this plan is a day that we are choosing not to make that happen. And that's something that I would really like to see change.
Okay, and let me stick with you for one other topic that came up in your comments, Rob's and others, and that's the underlying data to help this work. So if you look at the requirements that are out there, and there is, as you know, CDC guidance on this, when tests are performed, all of that data is supposed to be shared in a timely way, including demographic information, test results, et cetera, which should be a helpful foundation for doing exactly what you said, localizing where outbreaks are occurring in a timely way, helping to guide the kinds of interventions that we've talked about today. If they're limited resources, we need to be spending them well. And yet that doesn't really seem to be coming together. Interoperability issues and so forth. Rob left, but from his standpoint, I guess I hear this a fair amount from Google is, oh yeah, all these are technically solvable problems, but yet they persist. So thoughts on how we can get the data needed to support progress in this direction?
Yeah, it's a patchwork problem, and there are many gaps that I think require attention in order to improve the overall performance of our system. But one area that I'm particularly passionate about is the data collection on patients and their close contacts. Every time a case is identified, they should be interviewed by public health and asked a number of questions about who are you, where do you live, who have you been in contact with. The CDC makes available a form that public health departments can use to collect that data. And this is standard epidemiology. This is something every department does. The problem is that there's often not the epidemiological or analytical support in order to analyze that data and make use of it for decisions. There's just not enough analytical expertise to go around. And I think that's an imminently solvable problem. I think over the long term, we need to improve the number, frankly, of epidemiologists that are available to work in public health departments. But in the interim, this is a skill set that is available in private industry and could be formed, for example, in partnership with industry analytics experts, And so I think that right now is a gap that I see is very fillable.
And let's maybe I can go to Robin on this point. So we've talked about the need for additional public health funding, and some of that is coming, and I'd even be willing to stipulate that there will be more. But I also would probably say that it's probably not going to be enough in the short term to get this kind of comprehensive infrastructure in place. And so in the U.S., as we talked about in the first panel, we're going to end up depending a lot on businesses. And as Raj mentioned, there's some that have the resources to do this, others that don't, but maybe could be supported by the public sector more, public schools, healthcare organizations. So Robin, on the healthcare organization side, we have seen in the work that we've done at Duke-Margolis some healthcare organizations partnering with long-term service and support facilities, especially those that have moved to new payment models and new ways of delivering care that get at issues like social drivers and kind of the root causes of why people are having health problems. Does that seem like an important supplement to the public health side? Can you see that maybe filling some of the gaps that you've identified?
I can see that happening, and in fact, again, it does happen on a we're doing some work right now in the Pittsburgh area with UPMC and a number of our providers around this very thing. I think the challenge is it's not the fact that we don't have the potential to make it happen. It's that we actually have to have the infrastructure to make it happen. What I worry about is that where is that money going to go? If that money were used to actually bring together these public-private partnerships to actually make this happen, and we had a framework for this kind of analytic work that could go on, I absolutely think it can happen. We have the skill sets. People have the skill sets, and we have examples of this going on. You guys are doing it. It happens across the country, but it isn't consistent. So I would like to see some of that money actually be used at the local. This is going to have to happen at the local level. It doesn't happen at the state level. It has to happen at the local level where these kinds of collaboratives come together. And I mean, maybe there needs to be incentives built in to make it happen. I'm not exactly sure. Maybe it gets tied to some kind of value-based payment effort. But the truth is we have the mechanisms to make it happen. It's just the infrastructure isn't there. I mean, our nursing homes are required to send our data to CDC, and yet we're already seeing that they're having problems doing that. So it's not that they don't have a structure for doing it, it's getting those data to CDC and making it happen on a consistent basis. This is where a collaboration, I think, could be fantastic.
on issues like data sharing and on support for these best practices.
Absolutely.
So I see Raj nodding, and Raj, you know, you've dealt with, you know, Ebola outbreaks, all kinds of global public health problems outside the U.S. I wanted to ask you a little bit about how this expanded effort in the U.S. compares to what you've seen, what you've led around the world to get these kinds of responses in place, often where the existing infrastructure wasn't so good, but mainly would like to hear your thoughts about how Rockefeller, working with groups like the ones on this panel, could really take advantage of this call to action.
Well, I think I would add maybe two thoughts. The first is, while I agree with each of the last three panelist comments, I don't, at the end of the day, think that we can absolve the federal government of responsibility to lead here. And, you know, I suspect, you know, as hard as it is to imagine, I think at some point the CDC and the federal government must and needs to produce some sort of guidance, because, you know, when Rob says I'm hoping that public-private can handle the coordination of this, you know, the other way to handle the coordination is for an authority, either a large state or a collection of large states, or the federal government, to offer some guidance on how to keep Americans safe for the next 18 months. And if we assume this is 18 months, and now I think we can assume that complete lockdowns are going to be rare, even as we see reemergence, it is absolutely a federal government responsibility to keep its citizens safe. And so I just want to be careful not to absolve the federal government and the CDC of offering that kind of guidance. I think second, you know, I think Rockefeller, Duke, Hopkins, and all of us working together do need to come together and do basically exactly what both Rob and Robin said, which is, you know, produce protocols, guidelines, guidance, and fill the void for now, in the hopes that it can be picked up. I had meant to ask, when Robin was describing the nursing home process, you know, is it known? Does every nursing home director know where they can turn to and get a validated guideline? Because part of what I think they need,
absolutely not.
They need to be able to do that. And whether it's Duke or Hopkins, somebody with credibility, and we're happy to kind of play a facilitating and supportive role. It needs to step into that, because I deal, you know, on one hand, I get to work with experts like Mark on the national effort, and then I work with my kids' school. And, you know, there's a lot of distance between people who see the world the way Mark does and has all that science kind of to draw upon.
Absolutely.
And the way any one institution is managing their decision making. And they have, I think, no choice but to be fairly conservative in the absence of guidance from an authority.
It's absolutely true.
It seems to me like the fact that they keep hitting refresh on the CDC site, looking for guidance, not getting it, basically tells them we should not be doing asymptomatic testing, which, by the way, might be true for a school. You know, I don't know. Yeah. But it's certainly not true for a nursing home. And it might not be true for a school in a low-income community that's experiencing a surge in cases and also has to stay open because they're simply not willing politically to shut down for a variety of reasons. So
But I would also say that the guidance is one thing, and the guidance has been consistently fairly generic. But then it's the implementation that Caitlin was talking about, which is on the ground, which is so incredibly inconsistent. So even if you have the guidance, you don't have the wherewithal to make that happen.
Well, and that's where
you live.
Yeah, that's where I do think, not to cut you off, Robin, but that's where I do think philanthropy and others can step into the void and at least provide support to institutions that need it in order to create models. You know, I don't think we can pay for everything. This is too much money. But I think, Mark, you might have the best sense of how the money is moving through the states. My instinct is, if we all come together and lead, you know, and produce both protocols and demonstrations of what success could look like. My sense is that the federal money, which always lags, will follow those examples and try to replicate them. That's,
And if I could just
and
add
frankly,
to
if it
this.
doesn't, I don't know what we do as
No,
a
I think that's that's probably the best path forward. And by the way, as the moderator, I normally don't get asked the questions in these things, but fair enough. In this case, I do think that with examples plus aligning the funding, there is a lot of money that goes to nursing homes, that goes to the healthcare organizations that care for people in nursing homes, the health plans that support them, like what Michael Schramm was describing that Harvard Pilgrim is trying to do to help pay in a new way to address these areas. There are a lot of resources that can be mobilized, but it does start with a call to action that you all have collectively articulated really effectively, but not only articulated, to Robin's point, I think it's incumbent upon us not just to sit around and talk about this stuff, but to go do it. And with that, I've got about a minute left for each of you for some final comments. So how are we gonna go about doing that? Robin, you want to start?
I am the most optimistic pessimist you have ever met. You know, in some ways, hope springs eternal, but I actually think we're going to see some phoenix rising from these ashes. I think this has been a wake-up call around the challenges that we have. Particularly, this is a public health problem, just like the Ebola problem was in other countries. And I actually believe that if we start to move forward with the stakeholders, we can actually think about how we manage resources better and pool those resources. We have them in the United States. We're just not using them well. And I think we have greater opportunities to make that happen despite everything that's going on. So I am very optimistic about that.
Thank you. And Caitlin?
Big question. I think the plan that I've landed on for how we're going to make it happen is to continue to talk about and write and advocate for the ways forward that I think would best serve our country. And that's where I'm at.
We're looking forward to continue to work with you on that. Raj, any final words?
You know, my best case scenario is that we come together, we issue some, generic guidelines and protocols that introduce the concept of asymptomatic testing, that make serious the concepts of wraparound services and support for isolation, and that really deeply articulate the need to focus on equity and pinpoint target those communities that are lower income and minority that are suffering the greatest in terms of mortality, morbidity, and economic impacts. And I think if we do that, and if we succeed at getting more resources flowing through the federal system, the federal money will in fact hit states, and states will, in a desperate effort to stay open, allocate that money against whatever examples seem to be most effective in the public and private sectors in their area of jurisdiction. So Mark, that places a lot of leadership burden on your shoulders. So whether you're moderator or not, we're counting on you and counting on this team. I learned so much from everyone as part of this. I hope we get to stay in touch and work together. Thank you.
Yeah, well, I want to thank you all for that optimistic pessimism. It is a very challenging situation we're in, but as we've seen already in this pandemic, that does tend to spur actions that might not otherwise have been possible. And we do have a pretty clear path. As Caitlin said, there's a foundation around the community engagement with testing, tracing, and isolation that could be done in collaboration with businesses. You heard from the employer or private sector perspectives earlier, very much engaged in these same themes that will include addressing how we use tests more effectively, especially as they become better and cheaper, and work out these issues around asymptomatic testing, which seems so crucial for containment of the outbreaks, the data that can support that, and then very importantly, getting the funds. As Robin said, there are plenty of resources there. We just need to get them redirected to a much more constructive way to supporting reopening the economy and better health, especially for these vulnerable populations that have been so hard hit. So I think it's safe to say, I say goodbye to all of you for now, that you'll be seeing this group together again and working on the issues that we've laid out today is a true, I think, public-private collaboration with some guidance that will hopefully make both federal, state, and local government actions more effective as well. So I want to thank all of you on the panel for joining us, all of you who are have joined us for the event today. Just to highlight, we didn't need to say it, but at Hopkins, at Rockefeller Foundation, at Leading Age, at Duke-Margolis, we are obviously continuing to be heavily invested in these areas that are so important for health and economic recovery. So we hope to hear from you and look forward to seeing you on further webcasts. I do want to give a special thanks to our team at Duke-Margolis who helped put this event together, including Marianne Hamilton-Lopez, Becky Ray, Christina Silcox, Patty Green, and Elizabeth Murphy, as well as our colleagues at the Alexandria Summit. And with that, I'd like to turn to Lynn Zadowski. And remember to take yourself off mute.
Oh. Am I good? Can you hear me? Okay. Thank you so much. And a big thank you to our partners at Duke-Margolis, the Center for Health Policy, and a special thanks to Mark and Marianne. Thank you to the Alexandria Summit team and my co-founder, Joel Marcus, the executive chair and founder of the Alexandria Real Estate Equities and Alexandria Venture Investments. And a big thank you to all today's panelists and to everyone who joined to listen. We are very honored to be a part of this community on the front lines of fighting the COVID-19 pandemic. As we talked about today, the cases are spiking. We've seen in the last couple of weeks that cases nationwide are going up about 15% and rising in about 18 states over the Southwest and Midwest. And this last week, too, something we didn't mention, but we've seen resurgences of infection in countries that we thought where the spread was under control, like South Korea and China, where the capital city of Beijing had to place more than 20 million people under a new partial lockdown. So, you know, it's really important. How do we strike that balance? You know, how do we learn to live in this new norm? And as you, Mark and Scott Golub said in your op-ed on Sunday in the Wall Street Journal, the novel coronavirus won't simply disappear. The U.S., unlike Europe and Asia, seems to have decided not to crush the virus, but to try and reduce it to controllable levels. So we do need to learn to live with this. We need to learn to manage this, and hopefully in the fall, if there's another surge, we'll be able to keep the infection rates down. So it's clear that it will persist and that today's conversation is incredibly critical and important. And I do just want to call out, though, that we are making progress, and it's really been amazing to see over the last few weeks and months the life science community being able to quickly mobilize to combat the impact of this pandemic by enabling the new tests and clinical trials and starting to really form those needed, and as we talked about, many more much needed, public-private partnerships that will drive solutions. But until all these solutions are fully realized, the current new normal, with its economic uncertainty, skyrocketing unemployment, and social isolation, is simply not sustainable. So until there is an available mass-produced therapeutic or vaccine, we must map out a new status quo that will promote the safety and maximize the lives saved while allowing some semblance of this pre-COVID life and commerce. So together, we need to leverage our collective voice. It's powerful. We need to drive it to navigate this crisis so we can return to our better new normal way of life. And I guess kind of two take-homes from today: remember, behavior matters. And I loved what Andy said in the beginning, that we need to rethink our value proposition to make people feel and be safe. So with that, I'll say thank you all, and be safe, be well, and we look forward to continued discussions. Thank you so much.